I'm really glad that I can talk today about LEMS. And first, my words, I would like to say thank you for Global Genes and Allies and Rare Disease Network, the biggest patient advocate for creating this fantastic event, and let us, physicians and you patients, get together and deepen our knowledge and discuss more about this, I would say, horrible disorder which make people disabled. So thank you again for inviting us, and we're very humbled to be here. I apologize ahead that I may repeat some facts which Dr. Shea already discussed, but it's part of understanding what kind of treatment we have and how we're finding the target for it. So as you know, the disease was named after two very good scientists which work in Mayo Clinic. It was Edward Lambert and Lee Eaton. And they described this disorder in the 1960s of this century, last century. And they figured out all majority of symptoms, and actually whatever they started thinking, it's still until now as a fundamental knowledge about Lambert-Eaton syndrome. And we know that about 60% of patients with Lambert-Eaton are suffering as a result of the cancer. And we're always looking for it when we diagnose patients with Lambert-Eaton. But it's still 40% patients came to us and we couldn't find any underlying cancer, and we call this idiopathic autoimmune disease. And especially those who are younger than 50, if they don't have any risk factor like smoking or something else, they have a lower risk to have actually lower risk to have cancer, even we anyway will do all necessary workup, be sure that we are not missing anything. And I want to repeat just very fast about this cartoon. So you see this is actually a junction, which we call synapse cleft here. And when propagation goes here through the nerve, and those vesicles are released, and they went to the membrane and release all this acetylcholine, which going to receptors on the neuromuscular junction, muscles start working. So then we look in there, and we decided, what's exactly stop doing this? Why is it? So once again, this is a normal cartoon of this process. And if you see here, this is a calcium, what we say, voltage-gated calcium channel. So the normal release vesicles, normal acetylcholine, muscle working well, and then we have block. Antibodies block this part, and there is still acetylcholine going there. You can overcome with your strength, but if you look the difference, then you definitely understand why it doesn't work. So there is another treatment. For example, if we for some reason block potassium channel, what had happened? Then calcium channel stayed longer time open. And even it has already antibodies, it let acetylcholine go more and more in the cleft, and then muscle can work better. There is another. When acetylcholine coming here, what do you think if we block enzyme which degrade acetylcholine, and then we increase number of acetylcholine, right? And in other part, if we see these antibodies, we may remove these antibodies. So there is, in our understanding how a neuromuscular junction works, and when we know the mechanism when it's blocked, and what actually part of our body, our nerve, muscles, enzymes participate, we may try to apply our treatment to different parts and see if we can help more with the treatment. So there is a, whatever I say, small cartoon which give us a little bit more information. Let me make it bigger. So this is, here is a nerve cells, and it's propagate now a signal which going to axons over here. Oh, let me take this away. And then after signal came, synaptic terminal activated. So this is a calcium channels. So when you see the calcium will eventually come in, action potential there, it is open. When it's going in, it's activate vesicles, and those presynaptic vesicles will fuse to membrane and go out. And then it's activate channel, it lets potassium go inside, potassium, natrium, sodium, and then it's activate muscle work. So this is what I say when we know exactly how it works, we would like to apply our treatment. Number one, as Dr. Shea said already, LEMS may come a little bit early with all symptoms. So cancer is still too small to be detected. But we need to do whatever we could and try to find. If we find and treat, then we may not apply all other treatment. I haven't seen those patients like this, but literature say LEMS could be abrupted if you treat right. Regarding chest CT, yes, we do, because we have opinion that thymus is like a factory which may trade autoimmune antibodies against us, and this is probably true not only for myasthenia gravis and LEMS disease and for many others autoimmune disease. If we see this and there is residual tissue, it's better to remove than keep it. And then we start thinking what exactly therapy we could apply. For example, decrease acetylcholine degradation to stop it, and therefore many use pyridostigmine or mestinon. I don't know, possible many half of you experience already. Or increase acetylcholine presence in the cleft. What I say, we may use diaminopyridines or aminopyridines medication. Or quinidine, very nice medication. And again, then we're thinking if we can remove antibodies and use IVIG and plasma exchange or apheresis or plasmapheresis, it's the same name of the same, like a treatment. And last one, suppress antibody production. What we do suppress antibody production, we use prednisone, imuran, CellCept, cyclosporin. But this should be done very carefully. Be sure that patient doesn't have underlying cancer because it could make it worse. So we need to select patients. Again, I never heard use of rituximab, but maybe in the future. But again, we need to be sure that there is no cancer in underlying disease. So let me summarize some treatment. And I'm sorry, it's how we diagnose, and actually just repetition very fast, blood test, CT chest, whole body PET scan, and EMG. It could be different order, depends how fast you're there, but blood test takes usually from 10 to 20 days, so it's much easier to start with EMG. And the initial pharmacotherapy, it's really we start thinking about blocking the potassium channel and help acetylcholine going in. If it doesn't work, we go next. If it doesn't work, we go next. And this is like stepwise. So we use diaminopyridines, then we use mestinon, then we use IVIG, we use Plex, we use immunosuppression. But all these therapies have their advantages and disadvantages. And we clearly try to convince this for you. And not always we have a choice which start with, but we try to pick up the best medication. For example, so currently FDA doesn't have much, therapies in discussing what we have, but this is a list of medication that we can use according to FDA. There is no any kind of restriction with this medication. And if you look on this table, I'm going to give you just very short description on every each of them. For example, we use diaminopyridines. What they do, they I'm sorry, this probably first one is mestinon or pyridostigmine. So this medication blocks degradation of acetylcholine. But itself, it doesn't give you a lot of help when you do this. The side effect of this, people frequently feel diarrhea, some stomach upset because it's increase of number of vesicles, number of acetylcholine going through membrane, but at the same time in increasing some motion and movement. But using itself only mestinon, it gives, I would say, like possible 30% of your strength. It's not really help. In combination with other medications, it may be more help. For example, next one, it's Empira. This medication have like a famous, very famous, march patient with multiple sclerosis. It works, but now many start using this medication for LEMS, and it's effective, but not to the way what we would like to. So possible combination with mestinon is better, but still some side effects which people don't like it. And Empira, it's one of medication which has a higher complication or side effect seizure. So therefore, we try not to use this very widely in patients with LEMS disease. So another IVIG. So IVIG helpful. But there is not many study about it because possible when researcher use and there is no result, they try not to publish much. Some negative result we'll see, but the first course usually help. However, antibodies coming back. And therefore it has some restriction, but when you have no other therapy, it's helpful. You just need to put on chronic treatment. The same problem going on with plasma exchange. The plasma exchange is the same. It's working very well, but if you do not repeat at least every 2 weeks, antibodies coming back. So another treatment like very good with suppression with prednisone. But prednisone long-term given a lot of complication. And this side effect including lower vitamin D, lower bone mass, a lot of joint problem and fracture, and like gain weight and change in your mood, and some manic episode, and name it. I know patients like initial and then they hate this treatment. They like to get off prednisone as fast as possible. So another medication that we can use, diaminopyridines. So diaminopyridines is actually medication kind of a choice, but so far it's available medications only through compound pharmacies. And even those compound pharmacies are very high quality, you can get different content of this medication. It could be the same capsule, what you think 20 milligram. The real compound could be there only 50% of medication you're getting, or 125% what you take. And because it's changing all the time, it doesn't give you stable effect. So something should be done and have real, one of the pharmaceutical company work on it and have a stable dose, which we know that we deliver to patient at work. So another very good medication is quinidine. This medication, we think, blocks the same potassium channel, but side effects, it's unbelievable bad. It could suppress bone marrow, people getting a very low amount of white cells. So it means infection going a lot. They may develop another cancer what you don't like it. There is a lot of stomach upset. But medication itself actually works very well for LEMS. But the risk and benefits when you weigh those two, you think that it doesn't work, and therefore it's better not using. However, there is some studies show it's not a. If you use with mestinon, it may work very well for the patient, and I'll get to this later. Doesn't work? Okay. So the FDA recently approved another medication, diaminopiridines, which name is amfamprидine. And this is different from 3,4-diaminopyridines, only the way that this phosphate salt. But this is given big advantage because pharmaceutical company can put exact dose what they want and deliver exact amount to the patient. And plus, it makes more stable, and you don't need all the time keep in refrigerator. And features the same. So there again, if you look here, and many of medications we discussed, I said that we would like to block here. It's actually about this medication, amifepridine, but not only this medication, but the other diaminopyridines and Ampyra and quinidine. They block this potassium channel, and then calcium channel stay longer open, and therefore antibodies cannot affect much, but vesicles could able to release more acetylcholine in this presynaptic cleft, and it's working. And this is kind of study we've done why FDA actually approved this medication. There was very interesting co-primary endpoints and secondary endpoints, which actually what they do, it's quantitative exam of muscle strength, and it's very objective after started treatment. There is a subjective evaluation by patient, questionnaire. This is clinical impression by physician who examine patient. And this very simple test. You run 25 feet. You run 25 feet, and we measure speed before and after treatment and see if any improvement. Not run, just walk. And it's 2 attempts. There is a little bit about the study, and it definitely shows that there is a real placebo group have a worsening, and treatment group has improvement, and we anticipate this because it's the same diaminopyridine. I don't want to keep this for long and make you bored, but the side effects actually not a very big compared to placebo. And most of the side effects, it's headache, a little bit dizziness, and stomach upset. Because acetylcholine move our bowel, and therefore increase kind of diarrhea, nausea, could be some dizziness, and headaches. And this is the same with every single diaminopyridine. Quinidine, this medication, which I would say, in my opinion, one of the best, but using it give you a lot of side effects and hard to explain patient what to do. And you see like a list of side effects here. I can't do this for whole page, and I don't want to, but medication is still okay. So there is a study that in combination with pyridostigmine, it's really work better for LEMS. And it works with blocking potassium channel, and I would like to show you some cartoons again. So the area of application, quinidine and diaminopyridines, all types, it's a potassium channel here. It's blocked, open voltage gate calcium channel, and therefore propagate better. When it's propagate better, our muscles works better, and I would like to show how it's actually works in reality. Dr. Perichet says that look in our heart, because heart is supposed to pump our blood. And there is very interesting cartoon. We have myosin and actin muscles. So when you already see propagation after, so it's on a muscle. This is when actual sodium going inside and calcium, and you see how nice one protein moving another protein. It's very microscopic. And this is kind of very, very macroscopic. And microscopic is look like this. Our muscle contracts, and see how it's smooth? But if you don't have enough pump, then it stops. Okay. just the next. So how pyridostigmine works? This is a chemical formula of pyridostigmine, and this is acetylcholine. They very similar in shape. So when acetylcholine going to presynaptic cleft, that this part of carbon going to serine, one of amino acid, and it's break on two parts. And these two parts actually choline and acetylcholine. When you added pyridostigmine, this part block enzyme. And enzyme cannot get to acetylcholine, and therefore amount of acetylcholine is increasing. And this helps patient too. And I would like to show another cartoon, how it's work on the molecular level in reality. So this is actually protein or enzyme, acetylcholine esterase. And if we go structure down, you see all this coil, double loops, and now you will see active part of enzyme, which prepare to get this acetylcholine degradate. It's taken a few seconds, but I found that it's going to be interesting to see it. It's more understandable than I tell you this 20 times. So you see this enzyme, it's lying there on one of the part of protein, very active. And then we have, it's a glutamate, histidine, and serine. This is one of amino acid, which is very active in this part of enzyme, especially with the oxygen here and hydrogen. And when they connected together with acetylcholine, they created molecule of water and therefore break a bond. And this is actually, see this carbon atom, and this is formula of acetylcholine. And this acetate, and this is choline. This is how they work together. So now you see it coming to the cleft. And this enzyme sitting just next to receptors. The work of our body to be sure that it's not too much. And in reality, it's removing anyway. If it's 6 cells or not 6 cells, it's working. So when it comes here, it create a new bind, new connection. Oxygen, hydrogen, they create water and they break. Going there. So, see, then we have serine attached to acetate and going separately, and we have choline separately. Now a new molecule of water coming there, it oxidates, and acetate released to cleft again. So after both part of acetylcholine released to cleft, it's going to be reabsorbed by presynaptic nerve-ending axons, and again synthesized to acetylcholine, which going to be recycled. So on this level where mestinone works, it blocks this transaction. It's not an antibody, but this is really good blocking. And now both of them going out of the cells. You'll see this, and we'll go forward. Okay. So there is some very interesting studies which done in Spain regarding IVIG, and those IVIG treatments were emphasizing not only for LEMS, but actually for dermatomyositis, polymyositis, and myasthenia. But I just would like to, and I bolded this part which belongs to LEMS. And they say, yes, the study works, actually. And when we do CMAP study, it means EMG, neuroconduction study, we see the muscle response is much better. But there is no real study to tell how its long-term treatment works. We know it's short term. So another these features of VIG, people use the same protocol for which is for any single autoimmune disease. You use 2 grams per kilogram, divide it on 5 days, do 5 days in a row, and you can continue a few weeks or months to maintain this process, but how much longer you can do it. But again, if there is some associated inconvenience, discomfort, you have always central line, you need to keep this one open, you need to watch it, you need to be sure that there is no infection going on, some side effects, not very pleasant, headaches, irritation of meninges. But again, if it works, you use it. But it may work in combination with diaminopiridine, it may work in combination with pyristigmine, and it's work. At least you're functional, you continue working, you continue walking, it's good. It's good for you, good for us, and we're glad. So another treatment, Flex. It's a plasma exchange, very popular, but in reality, the same concept. We're taking blood from you, putting in a machine, clean it from all antibodies through the special filters, and then after and resins, and then clean blood coming back. So it's set up the way that the certain sites of proteins getting removed, and we assume that most of them this antibody. And it works well, but in 1-2 weeks, antibodies coming back. So it's, again, should be like a chronic. This is treatment actually required real central tunnel line, maintained on the chest, and it's really inconvenient for many reasons. And this is open gate for a lot of infection going on, So if you're able to maintain for a long time, it's good, but treatment itself should keep you on the leash close to hospital. You cannot go anywhere. You cannot even do this at home. It's a good treatment, but you need to be close to the hospital. Be sure that this hospital knows what they do, because not every single lab is very good. Yeah, you have a question?
For extreme treatment, if it's too bad, you can use that.
I'm sorry, I can't hear you. Can
You use that treatment when the patient gets too bad, or?
No, you can use this treatment the same time. You can use treatment if any medication not available or patient cannot tolerate medication, you can use it.
Where you said it also opens up infections.
Oh, it's open infection because a big tunnel catheter which going directly to your heart. This is what I say. Whatever you have outside open, any central lines, it's always a risk for infection. It's not a risk for infection itself, but this kind of need to be maintained always very carefully. Not to block, not to clot with the blood and other. So it takes some, I would say, consideration how to maintain this, and it should be nurse who help you with this. It's hard to do it yourself.
And how often would a patient have to do this?
They do the first, the same as 5 sessions in a row, like we do every other day or every day, and then maintain once per week, once every other week. Because if you don't do it, then antibodies coming back. And like Dr. Shea said, it doesn't matter the amount of antibodies. So antibodies present, you see it. They block you. Yes, Patrick.
I did the plasmapheresis. I went 5 days in a row, and then I went to going to every other week, once a week, once a week. And when I went to once every other week, there was definitely a loss in strength and balance. So I went back on the regimen of 1 every week.
Yeah. And we had this experience with Patrick, but we decided eventually to stop. He's working, he's teacher in the school, it's kind of inconvenient for him, very functional, and plus we started using diaminopiridines, which gave him a lot of strength. We decided, okay, let it put on the back. If something happened, he would be not able to use medication, we'll get back to this treatment as well. But see, we need to do it at least every 7-10 days. Otherwise, effect is fluctuating, and you're getting like better, then worse.
Yeah.
It's we know.
How long has a patient stayed on, plasma exchange?
You may stay forever.
Or might stay forever. Have you seen that? Or
They eventually, people stop because they got tired, they do not tolerate this treatment, they don't want to be on a schedule every day, like 10 days or 7 days be in hospital, but this is kind of like dialysis.
Yeah, but that's for.
But there is another side effects which may happen. People develop allergies to citrate, to medication what we use to clean blood, and they risk for eventually developing some bleeding as well. So it's, you know, I say there is no good drugs. Every drug has a side effect. You drink too much water, you can die too, you know, because it's a shift between potassium and sodium.
If someone has also been diagnosed with a cancer and they're also undergoing cancer treatment, is this?
So that actually when patient diagnosed with a cancer, we can use this treatment because it's not immunosuppression, but sometimes we can wash out the good antibodies as well, and the natural way to fight it. The cancer, the same like is with IVIG, but IVIG improving the way to immunoglobulin G be in the body and working, so it may be helpful for the patient with the cancer when you cannot take any immune suppression like Imuran or Cellcept or cyclosporin or something else. You know, there is always, we need to put all together and create personal therapy.
Right.
But one of the medication could be always be fundamental, which I think it's our obligation to put there. It's a diaminopyridines, and it's compound or new phosphate salt of this variant. They're good, they're helpful. You can add it mestinone, you can add it IVIG or something else. Combination, because they affect different area. We notice one medication affect potassium channel and make calcium channel be open longer. Another affect enzyme which try to degrade acetylcholine, so you double increase number. Third, you have IVIG, you're removing antibodies, they're less, and then calcium channel blocker works better, or actually with a plex. And if it's no risk for cancer, you added immunosuppressors, and then production of antibodies drop. So you know, sometimes you can be on all four modalities, and look, if you really bring up your health and decrease disability and start functional, who knows, God bless you. You know, that's very important. So immunosuppression, again, there is very known medication. We use this for years, not only for LEMS, we use for myasthenia, we use this for, there is another like methotrexate, we use for myasthenia, for lupus, for CADP, for many autoimmune diseases. But you always need to be sure that there is no underlying cancer. And therefore, even we say that one of my patients has no cancer, I would repeat all workup probably every 2 years or every 1 year. Just PET scan and chest CT to be sure that they're not missing anything. Even in this case, all our study, what we can do now, I don't think they're perfect. We can miss it anyway. But if it's getting a little bigger size, we eventually can pick up. We just need to be always aware about this, be always conscious, and not to forget to do it. And my conclusion, so medical therapy is always tailored to the patient. Every single of us, every single of you, it's an individual which has some preferences and got a tolerance to one treatment or another, and preference to one another treatment. And not every single treatment helps the same way to everybody. It's the same like with our food, you know. Somebody likes sashimi, and somebody look on sashimi and have the same effect like from mestinone whole day diarrhea, you know. So it's a real preference. We cannot to push, but this is still trial. We always try to do the best what we could to help. And only work together. Patient, physician, then it works well. It cannot be on the one side. And in the end, I again would like to say thank you for your patience, thank you for being here. And I'm really honored to give this discussion to the lecture, and I hope that everybody gets some more understanding what actually target we would like to find, have to fight, and have to get this disease under control. Thank you. Any
Thank
questions?
you.